us. My name is David Grace. I'm an addictions pharmacist at the Center for Addiction and Mental Health, and I'm here to talk to you about methadone maintenance treatment in the community and how pharmacies should manage misdoses. Today I'll be talking about our role in handling missed methadone doses and what we can do to keep our patients safe. I have no current or past relationships with commercial entities and no conflicts of interest to declare. My talk for today will begin with an overview of methadone maintenance treatment and how it is dosed so that we all have a basic understanding of guidelines and are on the same page. Then I will discuss what the impact is of missed doses, how we manage missed doses, and strategies to prevent them. Lastly, I'll review ISMP's 5 key points to consider when managing missed doses. Before getting into the material, I'd like to present 2 cases that highlight the key themes of today's presentation. First, we have Jerry, who's 34 and has been a patient of his family doctor for 8 years. He began snorting oxycodone at age 24. By age 30, he was using IV heroin daily. He tried to stop using opioids but could not cope with the withdrawal. Jerry started methadone maintenance treatment a week ago and has been coming to your pharmacy daily. He recently missed his dose 2 days ago and complains that the methadone is not quote-unquote holding him. He appears frustrated and complains of coming to the pharmacy daily. He hands you a prescription for methadone 60 milligrams daily, observed for 1 week, and asks for his dose quickly because he is in a rush to get to work. Our second case is about Nancy, who is 42 years old and has been in a methadone program for 2 years. She has been stable for the last 6 months on 85 milligrams of methadone daily. The pharmacist observes her dose once a week on Tuesday, and she receives 6 carry or take-home doses. This week, Nancy does not come to the pharmacy on Tuesday as planned, but instead arrives on Thursday. When you ask her why she didn't come on Tuesday, she reports that she was very busy with a personal matter, so she stretched out her carries to last her longer. She no longer has any methadone today and decided to get her drink and 6 carries as usual. You notice that Nancy has not seemed herself lately, and today she is wearing sunglasses and looking down to the floor while speaking to you. So, to begin our discussion about missed doses, I'd like to start by talking about what methadone maintenance treatment is and some dosing guidelines. Methadone is used for the treatment of opioid use disorder. The DSM-5 definition of opioid use disorder is the problematic use of opioids leading to clinically significant impairment or distress despite adverse consequences from continued use and the development of withdrawal syndrome when opioid use stops. Methadone and buprenorphine are used to treat opioid use disorder. Buprenorphine for opioid use disorder is commonly referred to by its trade name Suboxone, which is a combo product of buprenorphine and naloxone. However, it is not the subject of the talk today, so I will not be referring to it after this slide. These 2 medications work to relieve withdrawal symptoms, reduce cravings, and can also be used as analgesics. Methadone is the older of the 2 and the most studied pharmacological treatment of OUD. Methadone maintenance treatment is a treatment program that uses methadone liquid in a structured program. It is associated with improved clinical outcomes, which can be a decrease in mortality, a decrease in criminal activity, an improvement in quality of life, and this is why it is the gold standard of treatment. Methadone can also be considered substitution therapy, whereby we are replacing one opioid with another without the euphoric effects associated with opioid use. When prescribed appropriately, methadone will alleviate withdrawal symptoms without inducing euphoria. In a sense, it is a form of harm reduction that leads to positive outcomes, such as reducing unsafe administration via IV routes. However, it is common for us as healthcare professionals to want to correct our patients and set treatment goals for them. It is important to remember that patients will be in different stages of change and they will need to understand what their goals are and how methadone fits into this picture. Having said that, it is important to understand that relapse is the part of the recovery process. It can occur at any point in recovery, so it must be met with empathy. During a time of relapse, it is helpful to refocus our patients on past achievements, as you will find that patients will perceive a relapse as a failure. Our role as our pharmacist is to reframe it and encourage the patient to use this relapse as an opportunity for learning. As we will see, missed doses can be a sign of clinical instability. We'll want to consider if they are on an adequate dose and whether or not the dose is still safe at this time. Given its effectiveness, methadone is not without its limitations. It is a particularly high-risk medication with a narrow therapeutic index, and much attention is paid to how it is dosed. First and foremost, it is a CNS depressant, which can lead to respiratory depression and causing death. That risk is significantly higher with concomitant benzo use or other sedating medications. Understanding the pharmacology of methadone is closely related to how we dose methadone and how we ensure the safety of our clients. Methadone is a full mu-opioid agonist, which is in contrast to buprenorphine, which is a partial agonist. It is absorbed from the GI tract in 30 minutes and reaches peak plasma levels in the blood 2 to 4 hours post-dose. Elimination half-life is more than 24 hours, so once daily dosing is usually sufficient. And because of the long half-life, steady state is achieved in 5 to 10 days. What we are looking for when dosing methadone is that withdrawal symptoms is suppressed for at least 24 hours. Sometimes patients may describe the dose as not holding them. We really want to find a dose that suppresses the withdrawal for a full day without causing any excess sedation. We'll also want to investigate what withdrawal symptoms they are experiencing. At steady state, methadone is stored in the liver and it then perfuses into the system to maintain blood levels. It is broken down into an active metabolite called EDDP, which is what is measured in a patient's urine drug screen at the physician's office. Signs of urine tampering would be large amounts of methadone, suggesting that it was not metabolized. Given methadone's long half-life, dosing guidelines were created with this principle in mind. During the initiation phase, a physician is assessing for the risk of toxicity. The higher the risk, the lower the dose. In Ontario, the highest starting dose is 30 milligrams in patients with no risk factors of toxicity and with no recent abstinence. This is the full table found in the CPSO guidelines, which you can refer to for other dosing strategies during the initiation phase. Similarly, the same principle applies to dose increases during the maintenance phase. The highest dose increase should not exceed 15 milligrams in 3 days, and there is usually no good reason to stray from these guidelines. Again, rather than referring to the full table, I'll refer you to page 40 of the CPSO methadone guidelines. So with what we know about the pharmacology of methadone and the development of best dosing practices, we need to understand what the impact of missed doses can have. Moreover, given our patient population, the risk of missing doses is increased by the cycles of relapse and recovery. As mentioned, methadone has a narrow therapeutic index. Methadone can be fatal in single doses as low as 45 milligrams in non-tolerant individuals. A daily dose of 40 milligrams for only 3 consecutive days can also be fatal. In children, a single dose as low as 10 milligrams can be fatal. And the risk, of course, is increased when there are other sedating medications that the patient has taken. Clients are at highest risk of intoxication during the initial titration phase. In early stages of treatment, patients will often complain of withdrawal and may resort to using opioids to self-medicate. For this reason, the initiation phase is the most riskiest of stages. Patients should be encouraged to avoid using opioids as much as possible, or if absolutely unavoidable, they should be instructed to use the smallest amount possible to alleviate their symptoms. Remember that patients need to be educated on the risks associated with concurrent use. Moreover, using a sleep aid to combat insomnia is also risky and should not be prescribed. The first week of treatment is always the most difficult, as you try to titrate the dose and manage other risks. There is literature to support that the riskiest stage of methadone is in the initiation phase. Methadone-related deaths have been increasing between 2006 and 2008 and are linked to the highest percentage of accidental deaths relative to other opioids. Now, in the event that patients do overdose or are intoxicated before presenting to the pharmacy, we need to be aware of the signs and symptoms of intoxication, which include nodding off, slow or slurred speech, and pinpoint pupils. In these circumstances, patients should not be medicated and need to be reassessed by a physician. In Ontario, we now have the ability as pharmacists to provide our patients with naloxone kits so that their loved ones or others around them can provide early management of opioid overdose while waiting for emergency services. It should be noted, though, that the naloxone kit is not a substitute for emergency services, just an early intervention while waiting for them. To prevent toxicity, we can take measures to mitigate the risks, such as patient education, avoiding sedating medications, tapering down benzodiazepines use, and frequent visits to the pharmacy. The pharmacist will need to have accurate dosing records in order to make the clinical decision in the pharmacy, and a reminder that intoxicated patients should not be medicated until assessed by a physician. In our pharmacy, we print this table out of the CPSO guidelines as a guidance as to what needs to be done with misdoses, and we have it posted for easy reference. There's no need to commit this information to memory, but make it accessible in your workflow so that you can easily refer to it when needed. The Institute for Safe Medication Practices lists 5 points to consider when assessing misdoses, which I think summarize nicely the points we have already discussed. The first point is that there is a serious concern for patients who miss doses. Tolerance to opioids, including methadone, is lost rapidly. If the regular dose of methadone is given after a period of missed doses, there is a risk of overdose and death. Missed doses are an important indicator of patient instability and may be a symptom of a variety of problems, including relapse to alcohol or other drug use. As pharmacists, we are usually the first member of the interprofessional team to become aware that a patient has missed doses. Which leads us into the second point. Pharmacists should be able to easily track missed doses. All pharmacy staff need to be able to easily retrieve information to accurately determine if a patient has missed doses. The Ontario College of Pharmacy methadone policy requires that the time and date of methadone dose ingestion be recorded. Even though patients may be in a hurry and the pharmacy may be busy, pharmacists should always take the necessary time to check for missed doses and verify that it is safe to give the methadone dose before ingestion. We should advise patients at the outset of treatment that missed doses will be communicated to the prescriber, and you can even incorporate this information in the pharmacy patient agreement. I have provided 2 examples of methadone dispensing logs that are frequently used in pharmacies. Note that the log should clearly indicate when the dose was given, what the dose was, and if there were any carries given. It is also advisable to ask the patient to sign off that they received their methadone and to resolve any disputes about the number of carries given. This dispensing log is in a calendar format, where the patient signs and dates the time they ingest, as well as the doses of carries that they receive. You will note that the patient's file also contains a photocopy of the patient's ID, so that pharmacists who are not familiar with the patient are able to accurately ID them. If you are planning to do this, be sure that you receive consent from the patient to take their photo and keep it on file. The file also has the most recent pharmacy patient agreement. ISMP's third point speaks to the methadone dosing guidelines. During the first 2 weeks, the dose should not be increased unless the patient has been on the same dose for 3 consecutive days. They recommend that the prescription be canceled if 2 or more consecutive days are missed during early stabilization, and that there should be no dose increases until the patient has been on the same dose for at least 3 consecutive days. For patients at a stable dose, a clinically significant loss of tolerance to opioids may occur within as little as 3 days without methadone. Again, the prescription should be canceled if 3 or more consecutive doses are missed, and that the dose should not be increased after a missed dose. You may see that physicians are writing these instructions directly on the prescription, instructing pharmacists to cancel the prescriptions in these scenarios. If you do, it is important to communicate what you have done to your prescriber. ISMP's guidance comes directly from the missed dose chart. Again, I reiterate, have this table readily available so that you may consult it when needed. Guidance 4 states all missed doses need to be communicated to the prescriber. It is good practice for pharmacists to report all missed doses to the prescriber, whether or not this is specified on the prescription. If prescribers do not have timely access to this information, they may make clinical decisions which jeopardize patient safety. This also has many benefits, including the opportunity for the team to intervene early when doses are beginning to be missed, rather than reacting after several days have been missed. Some patients exhibit a pattern of missed doses, but not 3 consecutive missed doses, because they know the quote-unquote 3-day rule. Lastly, one missed dose may have important clinical significance. For example, someone who has level 6 caries may mean that they have missed several consecutive days. Lastly, pharmacists should work collaboratively with the physician to provide methadone in a safe manner. Pharmacists are encouraged to follow up with prescribers who are not following dosing guidelines. It may be an opportunity to discuss whether or not the prescriber has reviewed missed dose information. Putting all this theory into practice, it is often asked, how can we operationalize these principles into our daily practices? First, it is important to establish a communication plan with your methadone prescribers. Build a professional rapport with your prescribers and figure out the best way to communicate missed doses and dosing issues. Ensure all pharmacists and technicians are appropriately trained. Technicians can be very helpful in flagging missed doses when patients arrive at the pharmacy, or identify patients who have missed their dose for the day. As your practice grows, pharmacists and technicians need to be on the same page and work together when dispensing methadone for the operation to be smooth and efficient. There are now courses created specifically for technicians to understand the considerations of methadone. For pharmacy managers, understaffing can lead to errors or decrease the vigilance of pharmacists as they feel the pressure to see patients too quickly. Despite all best efforts to prevent scenarios that can put patients at risk, there may be situations where methadone toxicity is unavoidable or accidental. For these situations, having a contingency plan in place for situations that are unpredictable is very helpful. Whether it be an intoxicated patient or an accidental overdose, make sure you have a clear plan on who to contact and how. Plan ahead on ways to handle statutory holidays, and in the event of a dispensing error, refer to the Appendix 1 of the CPSO guidelines on how methadone overdose is managed. In conclusion, there is strong evidence for methadone for the treatment of opioid use disorder. Pharmacists need to have a strong understanding of dosing guidelines and the issues that can arise with toxicity. Pharmacists should also be familiar with ISMP's recommendations of what to consider when handling missed doses. So, back to our case study. For Jerry, who is 34 and recently initiated on methadone, he has missed a dose 2 days ago and complains of methadone not holding him. In this case, we can recognize that Jerry is in the early stabilization phase of treatment and has the greatest risk of toxicity. Jerry's previous prescription was for methadone 50 milligrams, and his prescriber has increased the dose. The methadone maintenance treatment guidelines indicate that the dose cannot be increased until patients receive at least 3 consecutive doses. We can see that in the top row of this table, we are instructed that the dose cannot be increased until 3 consecutive days of the same dose are given. So in this situation, we'd have to hold the prescription, possibly cancel it, and contact the prescriber for an appropriate prescription. Nancy was our patient who appeared to be clinically stable on 85 milligrams, but has recently stretched her carries for 3 additional. In this case, we can Putting all this theory into practice, it is often asked, how can we operationalize these principles into our daily practices? First, it is important to establish a communication plan with your methadone prescribers. Build a professional rapport with your prescribers and figure out the best way to communicate misdoses and dosing issues. Ensure all pharmacists and technicians are appropriately trained. Technicians can be very helpful in flagging misdoses when patients arrive at the pharmacy, or identify patients who have missed their dose for the day. As your practice grows, pharmacists and technicians need to be on the same page and work together when dispensing methadone for the operation to be smooth and efficient. There are now courses created specifically for technicians to understand the considerations of methadone. For pharmacy managers, understaffing can lead to errors or decrease the vigilance of pharmacists as they feel the pressure to see patients too quickly. Despite all best efforts to prevent scenarios that can put patients at risk, there may be situations where methadone toxicity is unavoidable or accidental. For these situations, having a contingency plan in place for situations that are unpredictable is very helpful. Whether it be an intoxicated patient or an accidental overdose, make sure you have a clear plan on who to contact and how. Plan ahead on ways to handle statutory holidays, and in the event of a dispensing error, refer to the Appendix 1 of the CPSO guidelines on how methadone overdose is managed. In conclusion, there is strong evidence for methadone for the treatment of opioid use disorder. Pharmacists need to have a strong understanding of dosing guidelines and the issues that can arise with toxicity. Pharmacists should also be familiar with ISMP's recommendations of what to consider when handling misdoses. So, back to our case study. Jerry, who is 34 and recently initiated on methadone. He has missed a dose 2 days ago and complains of methadone not holding him. In this case, we can recognize that Jerry is in the early stabilization phase of treatment and has the greatest risk of toxicity. Jerry's previous prescription was for methadone 50 milligrams, and his prescriber has increased the dose. The methadone maintenance treatment guidelines indicate that the dose cannot be increased until patients receive at least 3 consecutive doses. We can see that in the top row of this table, we are instructed that the dose cannot be increased until 3 consecutive days of the same dose are given. So in this situation, we'd have to hold the prescription, possibly cancel it, and contact the prescriber for an appropriate prescription. Nancy was our patient who appeared to be clinically stable on 85 milligrams, but has recently stretched her carries for 3 additional days. For Nancy, you may have noticed a pattern that she has been missing her usual observed dose on Tuesday and arrives on Wednesday. Upon questioning Nancy, she may admit to using opioids during the days that she missed. It is important to show empathy towards Nancy as she may feel ashamed about her relapse. In this situation, a dose reduction is required as she has missed 3 days. Again, it is important to cancel this prescription and document clearly what you have done. She'll need to be reassessed by a physician and a new prescription issued to you. Thank you for viewing the presentation.